Around 8-2.
Sir?
Yeah. Please start.
We will start at 8:05, sir. People are joining right now. Actually, there is a shift of the day. So people are coming.
I understand.
No, sir, you can start.
Sure. Good evening, ladies and gentlemen. Welcome to another exciting episode of Secrets of Neurology. Today is episode number 33rd. A warm welcome to our case presenters. And first time we are having Himachal Pradesh in our map. Warm welcome to faculties and participants from Dr. Rajendra Prasad Government Medical College, Thanda, Kangra. Almost nearing 3 years, and this probably is the largest running neurology web series at a global platform. And this has been achieved because of our two program directors, Professor Dr. Sudhir Shah, Professor and Head Department of NHL MMC, SBA PIMSR, Director of Neuroscience, because of his contribution to patients at large, society at large. Sir was conferred prestigious Padam Shri and Dr. B.C. Roy Award, and Dr. Sudhir Bhai Shah, major interest is into stroke, neurodegenerative disease, and epilepsy. Our second program director, warm welcome to you, sir, Professor Dr. Lakshmi Narasimhan Ranganathan, Director and Professor, Institute of Neurology at prestigious Madras Medical College. Many accolades equally to his credit as well. Paltu C Advisor, Amy Baker's Award, Best Paper Award by AN, Global Elsevier Atlas Award, and has been a contributing member to various national and international societies in the field of neurology. We are grateful for your insights, sir. May we request both our program directors to introduce the speakers, the participants from here.
Thank you. Thank you very much, Dr. Manoj Bhai, for that nice introduction. As has been told, this is one of the longest running teaching series, webinar series, especially for postgraduate students of DM and DNB neurologies. However, it has been very lively attended by many of the neurology colleagues, junior and senior both. And in conferences, they gave us personal compliment for having organized such a wonderful webinar series. Now, in that continuing series, we have now 33rd episode today. And interestingly, and to our great joy, first time Himachal Pradesh has agreed, and it is thanks to Dr. Amit Bhardwaj, Professor Amit Bhardwaj and his team, that we are able to have Tanda Rajendra Prasad Medical College, that is from Kangra, Himachal Pradesh, that will have today's case presentation and discussion. May I have the next slide, please? Dr. Oshin Mantro is a senior resident from the Department of Neurology, DRPGMC Tanda, Kangra. She will be presenting the case. Next slide, please. And her colleague, senior resident Dr. Monica Angra, from the same department, she will take the discussion further regarding this case. This will be followed by discussion from Dr. Ritin Sharma, who would be taking this further. Next slide, please. And Professor Amit Bhardwaj, Professor and Head of Neurology, he will do final discussion on the case. I think there is some order problem. May I go back on the slides first? Dr. Manoj, go back to the slides. I think Oshin is the senior resident, then Monica is also senior resident, and Dr. Ritin, all three are seniors. Okay, fair enough. And then Dr. Amit Bhardwaj, Professor and Head of Neurology from DRPGMC Tanda, that is Dr. Rajendra Prasad Medical College, Tanda. He will be the person who will give final words of wisdom and pulse of wisdom from the case. Dr. Amit Bhardwaj is a great friend, and he has a lot of interest in cognitive neurology, stroke care, and neuro-ophthalmology. He especially developed interest and contributed a lot to telestroke, providing expert stroke care through telephone. And in particularly in the rural India, providing the last mile neurology, what we can say. So that's a great contribution, and I think we should applaud him for his work for helping out the population in the distant part of the villages. Thank you, Dr. Bhardwaj, for accepting this invitation. And I also want to thank wholeheartedly my co-course director, Dr. Lakshmi Narsihan, for his unwavering support and continuous efforts for making this series successful. I also want to thank all the delegates for your so much zeal and your continuous participation and feedbacks, which has made it possible for us to run this show. There are delegates from India and neighboring countries, and some from the distant countries like USA, UK, Spain, Portugal, and other countries also. I also want to thank sincerely Mr. Shraddha and his team from the Globusel division of INTAS for the logistics support and the networking that they are providing, along with Dr. Manoj Kumar, Dr. Shweta, and others. So thank you, all the people who are pivotal in making this webinar series one of the most well-attended series. So today's case is about the case of neuropathy, a very interesting and important case, and I'm sure all of us will enjoy. So I request Dr. Amit Bhardwaj to take over from now. Once again, I thank you all wholeheartedly.
Thank you, sir. Thank you. Thank you very much, sir. I'm really thankful to Dr. Sudhir Shah and Lakshmi sir for giving us this chance to be here presenting our case. Dr. Oshin will start with the history, and Dr. Monica will take over. She will discuss the history and the differential diagnosis. Dr. Ritin Sharma, they will then present the examination part, which will be followed by discussion and investigation by Dr. Monica, and then final few slides by myself. So I think we'll start now. Dr. Manoj, should we start?
Yeah, yes,
okay.
Please.
Dr. Oshin, Dr. Oshin, please.
Good evening, one and all. Thank you for giving us this opportunity. I'll be presenting the case today, a case of a progressive weakness, which will be followed up with a discussion from Dr. Monica and Dr. Ritin. Starting with the case. We are presenting a case of a 55-year-old female. She is a resident of Kangra, Himachal Pradesh. She was admitted with us on 6th of March 23rd and still is admitted in the ward. She is a right-handed individual, is a housewife by profession. Chief complaint, she presented to us with the complaints of abnormal sensation of bilateral lower limb for 1 year duration, weakness of left lower limb for 7 months, weakness of right lower limb for 6 months, abnormal sensation of bilateral upper limb for 2 months, weakness of bilateral upper limb for 1 month. History of presenting illness, 55-year-old female who is a known case of CAD on medical management, is not a known hypertensive or a diabetic with no other comorbidities, was apparently all right 1 year back when she started complaining of abnormal sensation in bilateral lower limb for 1 year duration. Patient was able to do all her routine activities until 1 year back when she started feeling abnormal sensation in the form of thickened skin sensation and tingling sensation, which first appeared in the sole of the left foot, which gradually involved the sole of the right foot within 3 weeks duration. It was insidious in onset, gradually progressive to involve the left leg till the mid-shin region within a span of 1 month, which further progressed to involve the right leg mid-shin region within next 2 months duration. It was slowly progressed to involve both the thigh region, left followed by the right thigh within 3 months' time. History of cotton wool sensation of the ground, which was present, which started with 1 month of illness, and gradually she started feeling unsteadiness while walking in dark. There is no history of any other burning sensation. She could appreciate temperature of hot or cold water equally in all the parts of the body while taking bath. There is no history of dry mouth, dry eyes, degree sweating over any part of the body. There is no history of palpitation or postural giddiness. There is no associated complaint of constipation or bowel or bladder incontinence. There is no history of trophic ulcers over the lower limbs. 5 months later from the presenting complaint, there was a weakness of bilateral lower limb for 7 months. 7 months back, she started noticing difficulty in gripping the slippers by her left foot first. She also felt twisting of her left ankle while walking on a level ground. She had difficulty in clearing the ground, and while taking a step, her foot used to hang down. There is no history of buckling present. 1 month later, similar complaints appeared in the right foot, after which she stopped wearing the slippers because of the difficulty in holding them, and sometimes she was not aware of slippage of slippers. Difficulty in walking gradually progressed proximally in the form of difficulty in climbing the stairs, progressed to a level that she started finding it difficult to get up from the sitting position, first from the floor and later from the bed. There is no history of fatigability of weakness. Presently, she needs support to sit from lying down position and needs help from both the sides through stand, and while walking, bilateral feet make a slapping sound. She feels her right leg is more weaker than the left presently. She can turn in the bed, but with effort, but no history of neck falling back on rising from the pillow. Patient also complains of thinning of the left lower limb for past 6 months. There is no history of abnormal twitching of any body part, abnormal jerking while lying down in the bed or walking downstairs. There is heaviness or log of foot sensation of the limbs. 10 months later from the presenting complaint, she started complaining of abnormal sensation in upper limb, which was 2 months duration. She also noticed abnormal sensation in the form of tingling in her fingertips of the left hand first, which progressed to involve the right hand within a span of a month, which was insidious in onset, gradually progressive, first till the palms, then the wrist and the forearm over a span of a month. There is no history of burning or pins or needle sensation. Following which she complained of weakness of upper limb for 1 month. For the last 1 month, she also have noticed the weakness of bilateral upper limbs, which is insidious in onset and gradually progressive. It first appeared in the left hand, followed by the right hand in a span of 20 days. It started with difficulty in breaking chapati and mixing rice, and slowly she felt difficulty in tying the knot of her trousers. She had difficulty in holding the bottles with her hands. She can hold the spoon or brush with bilateral hands, but not with a firm grip. Slowly, she started finding it difficult to take them to the mouth for 20 days. Once she takes the spoon to the mouth, she can further guide the food to the mouth without smearing it. There is no history of hand going here and there while eating the food. She has difficulty in combing her hairs and taking bath, and she needs assistance for these activities. Darkening of the skin for 7 months. Gradually, over a period of 7 months, she has noted that skin of bilateral dorsum of the feet and hands have darkened, which progressed to involve the other parts of the body, including her face. Her face also has thinned out over 1 year. There is no history of loosening of cloth. In this picture, we can appreciate there is a darkening of the skin and there is a thinning of both the cheeks. There is no history of backache, neck pain radiating to any limbs. There is no history of shock-like sensation on bending the neck. There is no aggravation of any complaints with coughing or sneezing. There is no history of band-like sensation over the tongue. There is no history of headache, loss of consciousness, or any forgetfulness or behavioral change. There is no history of decreased vision, double vision, drooping of eyelids, difficulty in chewing, or loss of sensation over the face. There is no history of any facial asymmetry or difficulty in eye closure. There is no history of hearing loss or spinning sensation of the surroundings. She also denies any difficulty in swallowing of food or water or change in speech or difficulty in breathing. There is no history suggestive of fever, night sweats, weight loss, loss of appetite. There is no history of trauma. There is a history of swelling of bilateral feet present, which has decreased after the hospitalization. There is no history of any photosensitive rash or joint pains, recurrent painless ulcer in the mouth, or any history suggestive of Reynolds phenomena. There is no history of diarrhea, abdominal pain, jaundice, abdominal lump, altered bowel habits, cough, or hemoptysis. There is no history of any bone pains or recurrent fractures. There is no history of recurrent infection, irritability, or bleeding from any part of the body. There is no history of polyuria or polydipsia. There is no history of intake of any herbal or Ayurvedic medications for any complaints. There is no history suggestive of toxic exposure in the form of contact with pesticides. There is no history of any hypopigmentic patches or any swelling over any part of the body except bilateral feet. No history of contact with tuberculosis or any high-risk behaviors. There is no history suggestive of blood transfusion. Past medical and surgical history suggests that there were no history of any similar episodes in the past. She is not a known hypertensive, diabetic, or any thyroid disease, liver or kidney disease, but is a known CAD. History of gallbladder surgery, which was done 5 years back in some hospital. Drug history, she is a known CAD for past 1.5 years on medical management and presently on antiplatelet and atorvastatin 20 mg. Denies any intake of any herbal or Ayurvedic medication. Personal history, she is not a smoker, does not consume alcohol and is on mixed diet. Family history is no significant. Now summary part will be taken over by Dr. Monica.
Dr. Monica, you can start now.
So are my screen, is my screen visible?
Yeah, your screen is visible.
Okay. Good evening. I will take up the summary of this case. So we're having a 55-year-old female who is non-diabetic, non-hypertensive with a history of CAD in the past, presented with chronic progressive asymmetrical illness, which started with asymmetrical sensory symptoms suggestive of large fiber involvement, first in the left foot, followed by the right foot, which was insidious in onset, started distally, then gradually progressed proximally to involve mid-shin and then both thighs. Now, for the last 2 months, she has sensory symptoms of paresthesias in the form of tingling sensation in upper limbs, start with the left hand, followed by the right hand. There is no
Monica,
history suggestive of small fiber.
Dr. Monica, अपना slide show on कर लेना.
No history suggestive of small fiber neuropathy. Gradually, she had asymmetrical motor involvement in the form of distal weakness of left foot followed by right foot, which then is to proximal weakness of bilateral no.
Shweta, leaning proper.
Yes, sir.
There's no slide, no. Yeah.
Yeah, she's good.
Dr. Monica, can you hear me?
Should I start again?
Yeah, you start. Please start.
Sorry for the interruption. So in summary, we are having a 55-year-old female who is non-diabetic, non-hypertensive with a history of CAD, who presented with chronic progressive asymmetrical illness, which started with asymmetrical sensory symptoms, mainly suggestive of large fiber involvement, which involved the left foot first, followed by right foot, and then it progressed proximally to involve mid shin and then both thighs. For the last 2 months, she has also sensory symptoms in the form of paresthesias in bilateral upper limbs, which started with the left followed by the right. There is no history suggestive of small fiber or autonomic neuropathy. Gradually, she had asymmetrical motor involvement in the form of distal weakness of firstly left foot, followed by right foot, and then progressed to proximal weakness of bilateral lower limbs. And now for 1 month, distal weakness of bilateral hands have appeared. There is some suggestion of element weakness in the form of thinning of left lower limb present both in the thigh and the calf region, with hyperpigmentation of face and extremities, UMN symptom, cognitive changes, bowel and bladder involvement, cranial nerve or cerebellar involvement. So what is a neurological deficit in our patient? We are having a patient with chronic progressive asymmetrical element quadriparesis, which is right more than left, lower limb more than upper limb, distal more than proximal, with sensory, mainly in the form of large fiber involvement, without small fiber or autonomic involvement, without UMN signs, symptoms, bladder, bowel, cranial nerve, cerebellar involvement, with skin involvement in the form of hyperpigmentation with a history of CAD. So on the basis of history, where we will localize this case, for main highlights of our case is that patient is having LMN quadriparesis, which is asymmetrical, which is main deficit is sensory motor. And in sensory, it is a large fiber involvement, which is C. So if we have to localize, firstly, in LMN, we at anterior horn cell level, the asymmetry of this case, it favors that it can be a case of anterior horn cell involvement, but the sensory symptoms are odd for anterior horn cell disease. Then for root involvement, asymmetry, it favors, but there is no history suggestive of any root pains, and the weakness is not in the root distribution. Similarly, asymmetry, it also favors flexopathy, but there is no history of any pains, and the upper limb weakness, it does not suggest plexus involvement. Then in neuromuscular junction, the weakness in this patient is mainly distal, then it progresses to proximal. But in neuromuscular junction, the weakness is mainly proximal. In neuromuscular junction, you have two main entities, myasthenia gravis and LEMS. For myasthenia gravis, the weakness distribution is odd. There is no history suggestive of fatigability. For LEMS, it can be a paraneoplastic LEMS, but there is no history suggestive of any autonomic features. So neuromuscular junction is also a lower down possibility. For myopathy, the distribution of weakness is odd because in this patient, we are having a distal weakness. For myopathy of 1 year duration, the possibility can be inflammatory myositis, in which pigmentation, it favors dermatomyositis, but the sensory symptoms are odd for this entity. So lastly, we have possibility of polyneuropathy, though there is asymmetry, but it can be seen in mononeuritis multiplex, distal weakness more than proximal weakness, nerve distribution, large fiber involvement. So the main entity which appears to be most suitable diagnosis is polyneuropathy. So if it is a polyneuropathy, what are the possible etiologies which can be kept? One is the mononeuritis multiplex. Why we in mononeuritis multiplex, in this case, we are having asymmetry, but the few points are odd for mononeuritis multiplex because the weakness here, there is only main involvement of large fibers. Small fibers are less involved in this patient. There is no history suggestive of autonomic involvement, and there is no history suggestive of vasculitis. Second possibility we can keep is autoimmune. In autoimmune, mainly CIDP variant which is multifocal CIDP. In multifocal CIDP, we have two entities. One is the multifocal motor neuropathy, another is a MADSAM variant. In this patient, we are having an asymmetrical weakness with sensory symptoms, so the possibility of MADSAM can be kept. Third possibility is multifocal neuropathy, but sensory symptoms, presence of sensory symptoms in this patient, it make this entity lower down. Then fourth possibility, which can be kept, because this patient is, in this patient we are having hyperpigmentation with neuropathy. So paraproteinemia associated neuropathy, mainly poems or amyloidosis, these possibilities can be entertained. Then in infective causes, the most common cause like leprosy, it can be kept, but the odd points for leprosy is that there is no small fiber involvement, there is no history of any sensory loss, no hypopigmented patches, no deformities. For Lyme's disease, there is no history suggestive of skin lesions in past, suggestive of erythema migrans, no history of any facial nerve involvement, no history of radicular pains. For HIV neuropathy is mainly symmetrical neuropathy. It is distal symmetrical neuropathy and it is mainly painful. In this patient, there is no history suggestive of any pain and it is asymmetrical neuropathy. So this possibility is lower down. But in HIV, if a patient is having associated CMV polyradiculitis, so asymmetry can be seen in that case. But there is no history suggestive of bowel and blood involvement, so this possibility is also lower down. In granulomatous disorders, neurosarcoidosis is a very good possibility in our case, because in this we are having sensory-motor peripheral neuropathy. The age of the patient and the asymmetry, it also favors that there can be a possibility of paraneoplastic neuropathy, though it is a symmetrical neuropathy, but in some patients in which there is plexus involvement, it can be an asymmetrical neuropathy. There is no history suggestive of constitutional symptoms in our patient, no history of any vertebral pain or root pains. Then another possibility which we can think of is the drug-induced, but in this patient, there is no history suggestive of any herbal or Ayurvedic medicines, and also the neuropathy is asymmetrical, whereas drug-induced neuropathy is mainly symmetrical and it mainly involves the small fibers. In nutritional neuropathies, patient having hyperpigmentation with neuropathy, we can keep the possibility of niacin deficiency causing pellagra. Though hereditary neuropathy is a lower down possibility, in this patient, we are having asymmetry. It is a multifocal nerve involvement. So in hereditary neuropathy, one possibility which we can entertain is the HNPP, but there is no past history of similar episodes of weaknesses in the past which are painless and which showed recovery, and there is no family history in this patient. Examination part will be taken by Dr. Ritin.
So continuing with examination. In general examination, patient was conscious, cooperative, oriented to time, place, and person. Blood pressure was 110 by 70 millimeter of mercury. Right arm in sitting position, and there was no postural fall. Pulse rate, respiratory rate was normal, saturation was normal, and patient was afebrile. So there was no pallor, icterus, cyanosis, no clubbing. JVP was raised 4 centimeter above the mid-clavicular line. There was presence of pedal edema, which was bilateral, and it was a pitting type. There was no lymphadenopathy. On head-to-toe examination, hair were normal. Oral cavity, tonsils, gums, tongue were normal. There was no thyroid swelling. Nails were normal. On skin, there were no hypopigmented patches, no purpura over skin, no knuckle hyperpigmentation. There was a generalized skin darkening prominent on face, hands, and feet. No peripheral nerve thickness was there. There were no neurocutaneous markers. And no deformities were there. There was no painless ulcers or trophic changes. No high feet, hammer toes, or claw hand was there. Now this diagram, this picture shows on bilateral hands and feet. It is showing the hyperpigmentation of the dorsum of hands and dorsum of feet. On nervous system examination, higher mental function was normal. MMSC was 30 by 30. Cranial nerve examination, including fundus, was normal. Speech was normal. On motor examination, the attitude was the upper limbs were lying by her side and lower limbs were externally rotated, plantar flexed, and bilateral foot drop was there. There was no fasciculations. So as we see in this picture, there was bilateral foot drop, which was more on the left side. Along with there was a left toe drop. Bulk, upper limb bulk, that is arm and forearm, were comparable on both sides. On lower limb bulk, at level of thigh, on the right side, it was 39 centimeter. On left thigh, it was 35 centimeter. But at leg, it was 32 centimeter on right side and left was 29 centimeter. Tone, it was normal on elbow, whereas it was there was hypotonia on wrist, knee, and ankles. Power, upper limb at level of shoulder, the power was 4 by 5. At elbow, flexion extension was 4 minus by 5. At wrist, it was 4 minus. Finger abduction, adduction was weak. Lower limb hip examination, it was power on the right side was 2 by 5. On left, it was 3 by 5. Knee flexion extension, it was 2 by 5 on right side, 3 by 5 on the left side. At the level of ankle joint, flexion was 0 bilaterally. Extension was 2 by 5 on the right side, 1 by 5 on the left side. Inversion and eversion were weak, and toe drop was present. So EHL was also weak. Reflexes, there was generalized areflexia. None of the reflex were present. On superficial reflexes, corneal reflex was present, jaw jerk was absent, superficial abdominal reflexes were present, and plantars were mute bilaterally. On sensory system examination, a superficial touch or fine touch, it was decreased in the lower limb till mid-thigh. On both sides, pain and temperature, they were normal. Vibration was impaired, and position sense, it was impaired in the lower limb. So pain and temperature, they were normal. While vibration, it was in the bilateral lower limb, it was decreased up to mid-thigh, and in the upper limb up to mid-forearm, the vibration was decreased. Position sense was decreased only in the lower limb up to knee level. Upper limb, it was normal. There was no cerebellar signs, non-stegmus. Appendicular system couldn't be tested because of weakness. There were no signs of meningeal irritation. Spine was normal. Gait, it was toe first, slapping gait. So in this video, we will see the gait of the patient. So we, as we see, the patient is walking with assistance of 2 persons, and she's looking on the ground while walking. And it is a toe first gait with a slapping, tapping kind of gait. On systemic examination, the abdomen was distended and an old healed scar was present on the right side of the abdomen. Umbilicus was stretched transversely, as we see in the picture. Liver was palpable 2 centimeters below the right costal margin in the mid-clavicular line, and it was firm. Spleen was palpable 2 centimeters below left costal margin in the left mid-clavicular line, and shifting dullness was present. Chest examination, there was bilateral vesicular breath sounds and no added sounds were there. CVS S1, S2 were faintly heard and there was no murmurs. So what we added from examination, so we saw that as JVP was raised, pedal edema was present. There was atrophy of the left lower limb. There was generalized areflexia. There was no small fiber involvement, and systemic involvement in form of hepatosplenomegaly with ascites was there with hyperpigmentation. So diagnosis after history and examination. So after history examination, the patient was having chronic progressive asymmetrical LMN quadriversus, left more than right, lower limb more than upper limb, distal more than proximal with sensory large fiber involvement without small fiber autonomic involvement, with generalized apraxia without UMN signs, bladder, bowel, cranial or cerebellar involvement. And also there was assisted presence of hyperpigmentation of extremities and face, or hepatosplenomegaly with ascites and with old history of CAD. What are possibilities after history examination? CIDP associated with paraproteinemia, that is POEM syndrome or secondary amyloidosis. CIDP variant in form of MADSEM, vasculitic neuropathy, paraneoplastic neuropathy, or neurosarcoidosis. So investigations will be dealt by Dr. Monica. Dr. Monica, you can start sharing your screen.
So in investigations, firstly, I had the complete hemogram of this patient in which TLC was 18,000 and platelet count was 5,51,000. So there was some suggestion of thrombocytosis, and the peripheral smear, it was dimorphic blood picture with neutrophilia.
Dr. Monica,
There
your
is no
slides are
diabetes
not
in this
visible.
patient, and
Can you go with the full screen?
Dr. Monica, full screen करना.
so I will share again. Sir, now they are visible.
No,
No, not yet. Yeah, now it's visible.
Sir. Okay. So now,
but it's not still full screen.
so
Full screen, yeah.
so it is showing full screen on my laptop, sir.
Okay. Just try the next slide. आपका next change हो रहा है. अब next करना. क्योंकि हमारे पास यहाँ next change नहीं हुआ अभी. हाँ,
So
ठीक है,
you
all
log
good.
out and you log out again, reshare the screen.
नहीं, मन का बीच में ठीक हो गया था.
Actually, sir, we are having a net problem here.
आराम से करो.
So is it visible now?
Yeah, अब full screen करो.
Yes, sir.
Yes.
Is it
Now
visible?
it's okay.
Okay, sir. So in this patient, we were not having any history of diabetes, and the parameters like fasting blood sugar and HbA1c were also normal. Liver function tests were normal. Renal function test was normal. We were keeping the possibility of paraproteinemia associated CIDP. In this patient, calcium was also normal. Serum electrolytes were normal, and thyroid function test, it showed subclinical hypothyroidism. TSH was 7.57. The viral markers, HbA antigen, anti-HCV, and HIV was negative. So next test we did was nerve conduction study. In this slide, we can see that amplitudes in this patient, that proximal amplitude is less than 50% of the distal amplitude in the bilateral median nerve and the ulnar nerve, and the nerve conduction velocity, it is also less. In this picture, we can see that the proximal amplitude is less than 50% of the distal amplitude. So there was some suggestion of the conduction block, giving the suggestion of demyelinating neuropathy. And on F wave, F wave were absent in the median, bilateral median, and the ulnar. On sensory nerve conduction study, the amplitudes of bilateral medial and the bilateral ulnar nerves were decreased, Bilateral sural were non-stimulable. So after nerve conduction study, what we could conclude that there is some suggestion of demyelinating neuropathy. According to the criteria for the demyelination, we need only one, at least one of the following is present. Out of these 7, 1 should be present. In our patient, there was reduction of the motor conduction velocity more than 30% below lower limit of normal in 2 nerves, absence of the F wave in 2 nerves, and there was motor conduction block. So we were having a demyelinating neuropathy, and which appears to be acquired because of the presence of conduction blocks. Now, there was some suggestion of demyelinating neuropathy. So next investigation we did was CSF. On CSF, there was increased protein. Protein was 129 in this patient with cytology showing only 2 cells. So what we were having albuminocytological dissociation, a demyelinating neuropathy with albuminocytological dissociation. So possibility of CIDP was high. Now we know that in CIDP, the most common group which is associated with CIDP, it is paraproteinemias. So the next investigation we sent was serum protein electrophoresis. But in serum protein electrophoresis, there was no M band. Gamma globulin level, there was no M band which was seen in this patient. But when we sent the 24-hour urine for light chains, both the kappa free light chains and the lambda light chains, they were increased. The normal value for kappa is between 0.78 to 13.48. In our patient, it was 671.37, and in lambda light chains were also increased. It was 122.89. The normal ratio of the kappa lambda was in this patient, the ratio was kappa to lambda ratio was 5.5, which was much higher than the normal ratio of 1.65. On urine protein electrophoresis, total protein found in 24-hour urine, it was 2.43 grams. So patient was having a nephritic range proteinuria with no cast on microscopy. So a patient who has demyelinating neuropathy along with albuminocytological dissociation with some evidence of light chains in the urine, we kept the possibility of monoclonal gammopathy. So the next investigation which was sent, it was skeletal survey. And on skeletal survey, we were able to see that there was a sclerotic lesion which was present in the L2 vertebra. On chest X-ray, there was evidence of cardiomegaly. And when we did the echo, there was global hypokinesia. On ultrasound in the abdomen, to rule out any paraneoplastic, to rule out for any evidence of malignancy, ultrasound added that there was hepatomegaly. The liver size was 16.4 centimeter, spleen was also increased, and there was no evidence of any metastasis. There was free fluid in the abdomen. So hepatosplenomegaly with mild ascites. Ultrasound pelvis was also done to rule out any pelvic malignancy, but it was normal. Then on 23rd of this March, we got the report of CT chest and CT abdomen, which added some findings. So there was pericardial effusion, liver was enlarged, spleen was enlarged, and there were sclerotic lesions which were present on D9 vertebra, L2, L3 vertebra, right ala of sacrum, bilateral iliac bones, and there was no evidence of any malignancy. Now, since this patient was having CIDP with some evidence of light chains in the urine and hyperpigmentation on general physical examination, so possibility of amyloidosis was also entertained, and abdominal fat pad biopsy was also sent, but it was negative. For leprosy, slit skin smear was also negative. Bone marrow aspiration showed that there were plasma cells, which was only 3%. That is, it is less than 10%. Bone marrow biopsy report of this patient is still awaited. ANA by HEP2, it showed that it was positive 2+, and ACTH was also increased The normal values are between 10 to 46. In our patient, we were having 103.6 with a normal cortisol level. So in a patient who was having chronic progressive asymmetrical element quadriparesis, left more than right, lower limb more than upper limb, distal more than proximal, with large fiber involvement, with generalized areflexia, without UMN signs, bladder wobble, cranial nervous cerebral involvement, with hyperpigmentation, with hepatosplenomegaly, with ascites, what did the investigations added? That there was thrombocytosis, subclinical hypothyroidism, acquired demyelinating polyradiculoneuropathy, albuminocytological dissociation, sclerotic lesions were present over D9, L2, L3 vertebra, pericardial effusion, hepatosplenomegaly with ascites, light change in the urine with significant kappa lambda ratio, nephritic range proteinuria, no cast, negative abdominal fat biopsy, bone marrow showing 3% plasma cells, and adrenal insufficiency. So are we dealing a patient with Poems syndrome? So patient was given pulse therapy with IV methylprednisolone for 5 days, followed by oral steroids along with capsule pregabalin along with treatment of CAD. Patient weakness improved after the pulse IV methylprednisolone and she was started on oral steroids. Radiotherapy opinion is planned after PET scan. Discussion part will be taken up by Dr. Amit.
So we started this patient as a sure. Okay. So we started this patient as a suspected CIDP patient. Normally, when should we suspect CIDP? Classically, we suspect CIDP. They are reading since our MD times that we have a progressive severe weakness with sensory changes which last for more than 8 weeks with areflexia. We always think of CIDP. But we can also think of CIDP when we have a recurrent severe neuropathy, or we can have a patient who starts as GBS, acute presentation, but keeps on progressing for more than 8 weeks. Or at times, we can also think of CIDP when we have unclassified acquired neuropathy, but with features of demyelinating on neurophysiology. As about this patient, it started as a classical length-dependent neuropathy. History-wise, only point favoring demyelinating disorder was that there was less wasting, and we were having more of a large fiber involvement. But on neurophysiology, it was found to be having a CIDP-like disorder. So now we are the CIDP terms, we are now making it like a CIDP spectrum disorders, in which one side we have this typical CIDP, which is symmetrical, motor more than sensory, and other side we have these variants like DADS, like MMN, or like MADSM, which are purely sensory, purely motor asymmetric, and motor and sensory asymmetric. This is the article published in 2021 May. This is by the American Academy of Neurology, where they have given guidelines for treatment of CIDP, and it was a report of their joint task force. They have divided CIDP into typical and CIDP variants. The typical CIDP, we all know, progressive or relapsing symmetrical proximal distal weakness of upper limb and lower limb with absent DTR, duration more than 8 weeks. But the CIDP variants, they have slightly changed their name. The DATs, they are now calling it distal CIDP, distal sensory loss and muscle weakness, predominantly lower limb. And multifocal CIDP, sensory loss and muscle weakness in multifocal pattern, often asymmetric upper limb predominant and is more than one limb. You call that MADSM. And then we have this motor CIDP, that MMNCB, motor symptom with signs without any sensory involvement. In our patient, we were dealing with something like a multifocal or asymmetrical weakness. So what other DDs, we can think of this multifocal or focal CIDP. We can think of diabetic radiculopathy, plexopathy, entrapment neuropathy. We can think of HNPP. We can think of MMN. We can think of neurologic amyotrophy, peripheral nerve tumors, vasculitic neuropathy, and definitely MADSM. This is all other in the differential diagnosis of multifocal or focal CIDP. And if we have patient has pain, then it favors our diabetic radiculoplexiopathy or neurologic amyotrophy. If patient has normal sensation, sensory is totally normal, we can think of MMNCB. If patient has only focal involvement of only one liver, one nerve is involved, we can think of entrapment neuropathies or tumors. If there's history of family history is present, we can think of HNPP. And if it's ANA or ANCAR positive, we can think of vasculitic neuropathies. So differentiating between the major subtypes, these are the main 4 types of CIDP. There's a classical garden variety CIDP. These are the main variants. Out of these 3 variants, DATS is the only one which is totally symmetrical, and it is sensory predominant distal. If we see the nerve conduction studies in these patients, there will be no conduction blocks, and there will be symmetrical demyelinating features with prolonged distal motor latencies. Whereas these 2 variants, they are asymmetrical. MMN is purely motor, we'll have frequent conduction blocks, asymmetrical multifocal demyelinating features will be there, and snaps will be totally normal. Wherein MADSM, a multifocal acquired demyelinating sensory and motor neuropathy, we will have frequent conduction blocks, we will have asymmetrical multifocal demyelinating features. In these patients, the patient present mainly with weakness of upper limb more than lower limb and distal more than proximal. And treatment-wise, CIDP responds very nicely to steroid, IVIG, or plasma exchange. All of the 3 treatment modalities we know of. DATs do not respond to any of these 3, and DATs is more common with IgM paraproteins. Whereas MMN responds very nicely to IVIG, and MADSM can respond to steroids or maybe to plasma exchange. When we are thinking of patient of CIDP, what other systemic disorders we should rule out? We should rule out infections like HIV, hepatitis C, hepatitis B. We should rule out metabolic like diabetes mellitus, thyrotoxicosis. We should rule out autoimmune disorders like IBS, multi-system diseases like SLE, sarcoidosis, nephrotic syndrome, and other diseases like HNPP and hereditary demyelinating neuropathies. Then other group is the paraprotein associated CIDP, in which we can have various presentation like MGUS, B-cell lymphoma, CLL, and ultimately POEM syndrome, which we are keeping a strong possibility in our case. Just a few slides about the peripheral neuropathies associated with monoclonal gammopathies. We all know that peripheral neuropathy is very common. Even monoclonal gammopathy is also very common, especially in patients are older patients. But coexistence of monoclonal gammopathy and peripheral neuropathy doesn't mean that this is the cause for this. So they can be coincidental also. They can be purely coincidental. They can be in both can be there in same patient, but they might not be linked to each other. And how does this cause neuropathy? They can have high protein burden and protein deposition as in amyloidosis. They can have an immune mediated pathway of antibody damage to the nerves. They can activate the complement pathways. They can secrete cytokines and then damage the nerve. Or sometimes the lymphoproliferative cells that directly infiltrate the nerves and then can cause neuropathies. This myeloma group, International Myeloma Group, has given few investigations which should be done for these patients, and these include serum protein electrophoresis. This will give us whether it is M-band or not. Then immunofixation electrophoresis of blood and urine, which will give us the type of antibody we are dealing with, type of immunoglobulin we are dealing with. Then quantitative immunoglobulin testing has to be done. Then serum free light chain assays and serum heavy and light chain assays. So these 5 investigations are ideally recommended for a patient who is suspecting monoclonal gammopathy. Now, if we are a patient who comes out to be M-spike positive on serum electrophoresis and the immunofixation shows the various subtypes, depending on those subtypes, we can divide the gammopathy into these 3 main categories. So bear with me for some few minutes on this slide. It's a very important slide. It can be IgM, non-IgM, or light chain. The IgM, non-IgM means either IgG or IgA. IgD and D and E are not normally seen with this kind of disorders. So if we have IgM, and if patient has any of these symptoms, systemic symptoms like fever, night sweat, weight loss, anemia, thrombocytopenia, high IgM level, and rapidly progressive neuropathy, then we should think of Waldenstron macroglobulinemia or amyloidosis. If none of these symptoms are present, but we have sensiataxia, demyelinating neuropathy, or MAC positive antibodies, then we should think of IgM neuropathy, and the DATS variant come very high on this. If none of these are there, then it should be taken as a coincidental finding and is not a cause of the neuropathy. If it is a non-IgM, then again we have to classify it is a kappa chain non-IgM or lambda chain non-IgM. It's a kappa chain non-IgM. Then we have to see, are there any Crab symptoms or any systemic symptoms? If they are there, then we evaluate for multimyeloma or amyloidosis. They are not there, then again this can be just a coincidental finding. If it is a non-IgM, that means IgG or IgA with a lambda chain, then again we have to see, are there any Crab symptoms? Crab means hypercalcemia, renal failure, anemia, any bony lesions, any systemic symptoms, thrombocytosis, organomegaly, endocrinopathy, any of these symptoms, demyelinating neuropathy. If they are there, then we have to work out for POEM syndrome, multiple myeloma, or amyloidosis. And again, if they are not there, then again this can be only coincidental. If we are lambda chain on free light chains, then again we look for any systemic symptoms, rapidly progressive neuropathy, marked autonomic failure, significant weakness, or any Crab symptoms. If they are there, we evaluate for amyloidosis or light chain myeloma. If not, then again this can be purely coincidental. Again, diagnostic criteria for POEMs, we all know this. Major criteria include polyneuropathy and monoclonal plasma cell proliferation disorders. Both of them should be present, followed by other major criteria. One is required, like Castleman disease, sclerotic bone lesion, or VGF. Minor criteria, organomegaly, extravascular volume overload, endocrinopathy, skin changes, papilledema, thrombocytosis. Any of them is required. So in our patient, we had definitely demyelinating polyneuropathy. Monoclonal cell, we did not have that strong evidence. Sclerotic bone lesions were there, and we had some features from this also. Now, we were reviewing the literature, and we found that there were some case reports, and they were the opinion that in some patients, they do not have detectable paraproteins, even after serial testing, demonstrating a plasma cell clone in these patients require more extensive investigation. Because of our resource constraints, we cannot do any immunofixation. Also, we cannot do other high investigations, so we may be lacking somewhere. So in our patient, are we dealing with POEMs? The points favoring were polyneuropathy, light chain sclerotic bone lesions, organomegaly, thrombocytosis, endocrinopathy, skin changes, and edemyositis. But the points against were also very strong. The neuropathy was not painful. It was not uniform also. And kappa chains were also raised. Whereas in POEMs, it is mainly restricted to lambda only. So these were points which against the POEM disease. Second possibility, we thought of amyloidosis. Points favoring were investigation. We had both kappa and light chain. The ratio was favoring the kappa chains. Systemic involvement was there. Weight loss was there. But neuropathy type is very odd. Amyloidosis mainly has a small fiber neuropathy, the autonomic involvement, which were not seen in our patient. Also, the abnormal fat pad was negative. But again, we reviewed literature, and they told that some patients can present with purely large fiber neuropathy without autonomic involvement, or that can still a possibility which cannot be ruled out. Now, we are in a very rural setup, and we are really resource constrained, but the patient wise also and the institute wise also. But we will, if given a chance, we'd like to do this further investigation, and let's see how many we can get them done. We would like to do serum immunofixation to find out have any missed any paraproteinemias. Then quantitative immunoglobulin testing will require to do. Vasculitic profile, the full dsDNA, ANCA, and other profile we will require to do. Serum ACE we have managed to send, and we are awaiting the report. Whole body PET we like to do, though it's not available at our institute. We might refer the patient to PGI or somewhere else. Then we require to do a full endocrinopathy screen, FSH, LH, and free testosterone levels and other tests. VGEF was slightly costlier for this patient, so we cannot get it done. Renal biopsy has been planned. We recently have a nephrologist who joined our institute, and we talked to him. Renal biopsy can be done. And we would like to do a nerve biopsy if we have not reached anywhere to rule out vasculitis, amyloidosis, or sarcoidosis. At present, we are still treating the patient on the lines of Poems disease. We are taking radiotherapy opinion, and if you suspect a generalized disease, we will go for chemotherapy. If localized, we can go for radiotherapy. Thalidomide has been tried, and therapies targeting VGF also have been tried in this patient, though I don't think we can afford in this patient. So finally, I like to say that neuropathy is like finding the puzzles, the pieces of a puzzles, and to fit those pieces and to find out how much importance each piece has, and then solving the whole of the case. Thank you very much.
Dr. Lakshmi?
Thank you, Amit. It's a wonderful exposition for the students. I'm really grateful to you because it is you have done a very extensive and a lovely discussion on neuropathy. I am sure that the students would have been benefited by the approach towards the monoclonal gammopathy, as well as the entire spectra of large fiber neuropathy. And you've taken them through the various spectra of CIDP and even the latest task force recommendations of the CIDP. It's wonderful, and I thank the entire Himachal Pradesh team for joining us in this wonderful episode and making it as a real intellectual feast. I thank every one of you. A special thanks to Amit Bharadwaj. And
thank you, sir.
Really excellent. And bottom of my heart, I thank you for this. And over to Professor Sudhir Shah for his expert comments.
Indeed, I agree word to word to what Dr. Lakshmi said. In the limited resources setup, Dr. Bharadwaj and his team has done wonderful work. And the way he has nicely dissected, that is more important. Let alone the diagnosis. What is important is the approach, which he has very nicely elaborated. And the stepwise discussion of different neuropathies and why this is favored against others, etc., was a very nice learning feast for all the students. I have one question, Dr. Bharadwaj. When you see those sclerotic lesions right there, I mean, how does it help, or doesn't it exclude so many other things when you have already organomegaly and polyneuropathy of this type with skin changes and cardiomegaly, pleural effusion ascites? What do you want to comment on that?
Sir, initially also when we took the detailed history, our first thing was, are we dealing with Poem syndrome? But then thinking and then proving it was slightly tough in our setup. So we tried to do all these investigations. Though still sclerotic lesions, they favor us towards palmar dyscrasias. But we wanted to, do a systemic workup.
Oh, that's perfectly fine. That's perfectly fine. But where else we do see this kind of sclerotic lesions in any other neurological condition associated with neuropathy? I think there will be very few, hardly if any, I remember. But this is something which is straightforward linking to the diagnosis on the background of all these things which you have. And I think taking a biopsy from the sclerotic bone lesion would also be very meaningful. And it would straightforward give you a plasma cell cluster or something like that, because we had similar cases. And I do remember this is certainly a very wonderful case. And the points that you raise, which are against on clinical grounds against Poems, are there, but we have seen a lot of outliers also. So I can understand, but surely Poems would be the first on card looking to this, and very interesting. I have one more question there. I'm sure there will be people who have some more queries, but before that, allow me to ask you one thing. Because I really admire you, the work you are doing, particularly the stroke telephone system and helping the rural community. I have no words to compliment you enough, but at the same time, I want to request you to share your experience. How do you do this? And I mean, what drives you and what are the hurdles that you face? Because this is a community medicine question, and I'm sure all the neurology students will be benefited with your expertise on this subject. So would you please elaborate a little on that? How did you manage
that?
the system? How
Yes,
did you
sir.
set up the whole thing, and what were the hurdles, and how did you really deliver the goods? This is something which is very interesting for all of us.
Actually, sir, I was very lucky because Dr. Padma ma'am from AIMS, she was the one who initialized our telestroke project. And it was started in 2014. And that time our the Secretary Health was, he has worked in AIMS. So he was known to Padma ma'am. So that was how we kick-started this project. And then, sir, most of the MD medicine which go in the fields are students from the two medical colleges in our state. One is in Shimla, one is at Tanda Kangada. So because of those, we had very good links, personal links with those MD medicines. And whenever they had a problem, normally also they keep on calling us for problems. So whenever we had a patient of stroke, we had a channelize, we can have WhatsApp, they can show us images, and we can talk to a radiologist. And so it was more of like a personal communication and personal loop kind of thing, sir.
Okay.
But then again, sir, things keep on changing as those MD medicine got transferred to different places. New guys came up. Again, we suffered some setbacks. So again, we are trying to revive it. So that's how it's going on, sir.
Okay. Dr. Lakshmi, isn't it very
Yes, sir.
interesting that, I mean, to serve the rural community against only two medical colleges in the whole Himachal Pradesh, as I understand. So these people
Yeah.
are doing a great job.
Sir, in fact, I was so surprised. Sir, we have, that's what the disparity in the country. What is in Tamil Nadu, every state, every district headquarters has a medical college. Every district headquarters is a medical college. Roughly about 40 medical colleges are there. Each district has a CT scan, and every subdivisional hospital has a CT scan. So we have stroke-ready hospitals. Even the subdivision of thrombolysis is being done in the script program, even at the taluk headquarters levels, were guided by the physicians and neurology interactions. So I'm really, but anyhow, very glad that Amit has taken this project, and it's a need of the hour. Secondly, as you have rightly said, the CT guided the biopsy of the sclerotic lesion, which would have had it shown some plasma cell cluster, it is diagnostic. So you don't have to bother for any other.
Okay, sir. We will go for it, sir. That was
one and it is easy also. The CT is available.
Yes,
the radiologist
yes,
should be able to provided the lesion is not too anterior, but most of the lead lesion looked fairly accessible to me. So,
yes, sir.
So then I think it should be.
Yes,
I think we should try that. And
you will get done.
Yeah.